Usually I start my presentations thanking the organisers. For this one, I have to start apologising for not being here and apologise to the entire audience and to the chairman and my fellow colleagues. But unfortunately, I really didn't know about this session. And I was enjoying the most extraordinarily good session on HHT. I got a telephone call from Claire saying, "Where the hell are you?" But it is an absolute pleasure to be here. And the great advantage of it, because all of you, I suspect, have seen so many slides and so many PowerPoint presentations over the last day and a half, that I'm going to give you a PowerPoint slide presentation free talk. It will, of course, be brief, and it will be to the point, which actually I feel quite liberated, because I can say whatever I want to. But I do want to say a couple of things which I think are really important about sinus surgery and about making things clear. Because what I'm going to tell you is how I do it. And how long have I got? Because frankly, sinus surgery is so clear in my mind, I think I only need 5. How long have I got, Martin?
Well, you've got 15 minutes.
Oh, for God's sake. All right, well, there'll be time for questions. How do you investigate the patient who is a primary? Because I think that obviously leads on to the question, how do you investigate the patient who has recurred? I think it's really simple. You get a CT scan, you pop an endoscope up. Dead easy. Don't fool around with tests for atopy. Don't fool around with tests with immunodeficiency. For goodness sake, why don't we skin prick test patients beforehand who have sinusitis? There's a simple reason in my mind, and that is the rate of atopy in the normal population in Melbourne is 45%. It's a test with incredibly high sensitivity, but extraordinarily low specificity. So if your patient's got a blocked and snotty nose, has got sinusitis on the CT scan, they've basically got a 1 in 2 chance of having skin prick tests. What's the chance of that being relative? I think the body of evidence suggests strongly that for the majority of patients it's not. And for those who it is, we have the easy ability as operating rhinologists of reducing their inferior turbinate and giving them topical steroids. It becomes an irrelevance really pretty early on. Immunodeficiency, I'm going to talk about a moment. For the failed patient, I would absolutely not recommend that we do any tests of immunodeficiency for the primary patient, because what's the prevalence of common variable immunodeficiency amongst our population? 1 in 50,000, for God's sake. How many frogs do you have to kiss before you find a prince? A lot. And it's just not worthwhile, because Martin, you and I live in countries which have got nationalised health services. We have a cap on our budget. We've got to make every dollar pay, and that's not the way forward. So it's simple. You get the SNOT-22. I run my practice on SNOT-22s. It's the most absolutely fabulous of things. All of my patients fill out their SNOT-22 before they see me. They get, I'm going to make a tiny plug if this is not, this is a wonderful thing. You can say whatever you want to, because nothing's written down. For the Interforce program, which is wonderful, and I suspect the guys are out there now, the Interforce program will send to your patients a link back to your database, and you can send out SNOT-22, you can send out any sort of questionnaire you want to. It's all filled out before the patient sees you. So they have all answered the question, do you have aspirin hypersensitivity? And I think that's a real key question to ask of our patients. And that comes back, so I know they've all had a CT scan before they see me, they've all done their SNOT-22, they've all told me whether they've got better with prednisone or topical steroids, antibiotics, saline lavage, and how many operations I've had in the past, and whether they've got any other intercurrent medical illnesses such as aspirin or gastroesophageal reflux. They then go on and have their operation. And I really only do 3 operations, which makes it really simple. I do mini-FESS, which is effectively a large middle meatal antrostomy, and that's for disease confined to the osteomeatal unit or the maxillary sinus. If the disease extends to the frontal sinus recess, I do a comprehensive or full house FESS, in which case I do my best to anatomically open all of the osteo as far as I can. And if they have really, really terrible frontal sinus disease, they get a DRAF 3. They then go off and rinse and flush and spray with topical steroids, and the majority do pretty well. There is a percentage, which is about, I reckon, 20%, who come back with recalcitrant disease. And the question then is how to look at those patients. What do you do? And they fall into 2 categories. Category 1 is the ones who are anatomically not corrected. And those ones you take back to theatre. And I actually think that's the majority of the patients who fail. Most of our failures are technical failures. And so if they've had a comprehensive FESS, they go back and they have a frontal sinus drill out. And I think it's, it's relatively straightforward. If they've had a mini FESS, they go on and have a comprehensive or full house FESS. And they get everything as opened as widely as they can. Stenosis, whether it's with scarring or with edema or just because the frontal sinus ostium is small, is a common cause of recalcitrance. But then you've got the ones who are much, much, much harder, who are technical successes. As humble plumbers of the sinuses, we've succeeded in getting our plumbing right. But the mucosa is terrible. And those are the ones that really worry me. And I think there are 2 ways of thinking about them. You can think about their antigens, the bugs, and I did know about the talk on microbiology I'm giving tomorrow morning, so I'll elucidate this further with plenty of slides. And the bacteria have become so phenomenally difficult, thanks to the molecular microbiologists and histopathologists, that it's incredibly difficult to know what to do with antibiotics now. The thing that I think is that antibiotics pre-surgery is treating chronic rhinosinusitis. The treatment of chronic rhinosinusitis, I think for the great majority of patients, should not be with antibiotics. The evidence for efficacy of antibiotics for anyone with chronic rhinosinusitis outside of patients with CRS without nasal polyps with a total serum IgE of less than 100 is about 0. And I think that's sort of a sobering thought, frankly. So in the post-operative situation, I think people genuinely get post-operative infections, and I think that's a slightly different case where people have purulence and they have crusting. And I think it's entirely reasonable to use systemic antibiotics for a period of time after that, as well as topical debridement, saline lavage. Not topical antibiotics, but I'm actually starting now to use topical antiseptics. And Martin, this is a topic that I know that you've spent a lot of time thinking about and have some experience with. Ian, you may too as well, with photodynamic therapy. And I think for the really difficult patient, that sort of kill everything type of treatment, which is at an experimental stage only at the moment, may have really some real benefit for a small number of patients. The antigens are difficult, and we're still figuring out the way to use antibiotics, and in a small number of patients antifungal medication. Role of antifungals in the great majority of the recalcitrant patients, I think, is about 0. But then you come to the other side of the mucosal equation, which is the inflammatory side. And we have patients who have either got a wildly enthused local immune system which is reacting to antigens, and we haven't really entirely sorted these antigens out, but you don't get inflammation without antigens. So there's stuff which is causing their immune system to require dampening. And we can either do this medically, which we all do with our topical steroids, and I think there's an incredible opportunity for us in these post-operative patients to optimize the distribution of topical steroids. Saline lavage and adding topical steroids to saline lavage is, I think, been great, and most of us who do this with our recalcitrant patients seem to think there's some advantage. The thing that I have against that is we know that less than 5% of the drug, because less than 5% of the solution which the drug is administered, will actually stay within the sinuses, so it seems really grossly inefficient. And I spent Sunday at a really interesting computerized fluid dynamic symposium, and I think that very clever engineers and very clever pharmacologists are going to work out much better spray devices with potentially much smaller particles administered at a much slower velocity than our current sprays do, so that with much greater efficiency we're going to be able to distribute the drug better throughout the sinus cavity, and particularly throughout the post-sinus cavity. And the final topic is when patients have an immune system which doesn't work so well, where there's some sort of flaw in the immune system. And we've touched a little upon this, and this used to frankly be my life for a while, with treating patients with common variable immunodeficiency or the various other, fortunately, very rare immunodeficiencies, and they are terribly rare. However, having said that, what I suspect that we're seeing in a great number of our patients is local immune, mucosal immune deficiencies which have as yet been poorly characterized, because all of our responses aren't nicely divided into Th1 or Th2, for goodness sake, or immunodeficient and having an entirely normal immune response. There is a spectrum. And I suspect that the sort of patients that we see, and particularly the patients whom we see who are difficult, are at the bottom 5%. But our tests for immune function, to be entirely frank, are pretty hopeless. There is only one test that I reckon rhinologists should be ordering, and that test is total serum immunoglobulin, because what you want to do, the patients who you want to find are the patients with common variable immunodeficiency, and the reason for that is that if you treat them with intravenous immunoglobulin or subcutaneous immunoglobulin, they get a whole lot better. How do you find them? There are two things in their history which are remarkable. Thing one is they've all got lower respiratory tract disease, in my experience, and I'd love to hear of those of you who have a patient with CVID who only has sinusitis. I reckon they're really rare. They've all got lower respiratory tract disease. So that's a way of, as it were, triaging your patients. And the second one is they tell you this phrase: I'm fine so long as I'm on oral antibiotics. These guys have a different relationship with bacteria than do the average patient with chronic rhinosinusitis. They really do respond to oral antibiotics, and with a few days of coming off oral antibiotics, they know they're different. So when you hear that phrase, you think, There's a possibility here. And for goodness sake, you're still, rather than ordering 1,000 IgG levels, and for your one abnormal, or maybe 10,000, you'll order then 100 if you respond to that question every time. And so I think that focuses our attention on a patient group who's got a much higher hit rate than the average. And I think on that note, I will finish. And I'd be delighted to answer any questions, should there be any. Thank you for your attention.